Well, I said that we would now move on and we would talk about styles of interviewing. And as you can see, when we were talking about interviews that are conducted in a very specific setting, like the intake area of a community mental health center or in an emergency room, often the setting determines the style of the interview in the sense that there is certain information that the interviewer is expected to get in that interview. And therefore the style becomes more structured and what the person seeks is fairly specified. Now, that changes when someone makes an appointment with an individual psychologist where the anticipation is that this first interview is going to lead to a series of interviews. That is, it's going to probably lead into treatment. And often, well, we can probably break it into two groups of people. When people are referred to a psychologist, sometimes it's because of his or her style. That is, someone already knows the kind of the theoretical frame of reference the person operates from, and so they come because they want that kind of intervention. So it's fairly clear, somewhat clear to the person coming what they're going to undergo. In other cases, they're just being referred to somebody because they've been told this is a very good person. That is, a friend, or maybe, well, usually often a friend, went to therapy with this person and felt that they really gained a lot from it. And so this person comes to see that therapist. But let's start anyway with somebody who's coming into to be interviewed. Now, if the person is walking into the office of someone who's very client-centered, what do you think is going to happen in the first interview? What would you expect? What's going to go on in that interview? First interview, the person who's doing the interview is very client-centered, trained in Rogerian techniques. What's going to happen?
They're going to begin to ask the person about themselves. They'll kind of make them feel comfortable if they begin to open up and just kind of, I think, anticipate kind of what direction they're going to take with it instead of leading them anywhere, being specific. They're just going to wait and let the client, let the patient kind of take off with the interview.
Okay, very good. Sure. The therapist in this case probably isn't too concerned about what the content of the first interview is. The person is more concerned with letting the individual talk about whatever it is the person feels that they've come to talk about, because the interviewer's prime focus is on establishing a relationship with the person. And they believe that people tend to, if you remember when we studied the process of Rogers, there's kind of a belief that people get more and more in tune with what their real problem is as they have time to feel comfortable with the therapist. So in the very first contact, since the assumption is the person is not going to be nearly as safe as they will feel after a number of sessions, if there's really been good rapport between people, the focus when someone walks into a client-centered person's office is, how do I help this person to feel safe? How do I develop an empathic relationship with the person? And now, it doesn't mean, if you see symptoms, that is, if one saw acute depression, which is one that becomes of concern, or if you realize the person's hallucinating, it doesn't mean you wouldn't actively want to learn about that kind of a problem quickly. But most of the people who come in are not like that. Most of the people who come in for psychotherapy and come to a first interview are looking for help, and they're going to be coming for a number of sessions. So the question becomes, how do you get started? Now, in client-centered interviews, the focus is very much on the client, what the client feels ready to disclose. There's no pressure to disclose things the person is not comfortable with. There's usually a lot of movement on the part of the therapist to try to establish a sense that he or she really does hear the client, that they're really listening to what the person is saying. So they often try to reflect back to the client certain things the person has said as a means of creating inside the person in the room that that person is safe, that the therapist hears them, and that indeed they're going to work on just what it is the client is saying. Now, sometimes, of course, in that setting, the interviewer also may give the client some words to work with. So the person says, things just aren't going well. The therapist might say, it sounds like you're feeling discouraged. Yes, I'm feeling very discouraged. You sometimes give the person the language which makes the person feel better. They didn't come up with the word. But now that you've come up with the word and you've given it to them, they feel indeed you are listening. And it's establishing that sense between the two of you that becomes most important. Now, supposing instead this person has walked into the office of a cognitive behavioral therapist, a person who is really trained in the cognitive behavioral model. What do you think is going to happen in their first interview? What would you expect now from what we've talked about? Sure, Mr. Kim?
What kind of environment they're living in right now, whatever stimuli are affecting their behavior.
Okay. So you're saying there are going to be questions about the current environment, and there are going to be questions about current behavior. What are the current issues? And that's very accurate. What else? What else might happen would you think? Sure, Mr. Jones.
Look into what some maladaptive cognitive functions are of the patient. Would it be too early to do that?
No, that's very good. Because one of the things in cognitive behavioral treatment is you really are trying to focus on whatever the person identifies as their problem. So if the person could tell you that there is some maladaptive thoughts that they're having or behavior they're engaging in, you would want to explore that in the very first session. And in fact, that would probably be the focus of the questions you would ask. And what would be the difference between our cognitive behavioral trained person and our client trained person in terms of what happens, let's say, in the first half hour of the interview? Can you think of any things that you suspect would be different depending on the training of the interviewer? Now just think of what you've described. Sure. Okay. Sure. Go right ahead.
Wouldn't it be focused on observation as far as the action of the person and basically how the person thinking and feeling of themselves?
Okay. And now who would do that? Which of these? The client-centered person or the cognitive behavioral person?
Cognitive behavior person.
Okay. You think the cognitive behavioral person would be focusing on observing the person? Okay. We'll test that out. Okay.
Well, I was just thinking that from what we've already described, the cognitive behavioral therapist is going to start with questions, where the client-centered therapist is going to pull back from questions, or at least guiding questions, and take a more passive role.
Yeah, that's a pretty apt description, yes. I think actually, Ms. Bro, the person you described would be more the style of the client-centered trained person. That is, they would listen. They would make observations, but they wouldn't intervene. Whereas the cognitive behavioral person would probably start asking questions right away once they understood that the person thinks they're coming for this problem. And as Mr. Inman was just saying, you're going to have one person is probably going to be much more active with questions. That is, the cognitive behavioral person is probably going to ask a lot of questions, whereas the client-centered person is probably going to try to listen and simply kind of probe and nudge the client to tell more as they're ready. So we've got these two different approaches. Now, supposing the person has been trained psychodynamically, what do you expect is going to happen in a first interview if you have someone who has been trained in a more psychodynamic tradition? What would you expect is going to happen in the first interview? Mr. Jones.
Exploration of early experiences and talk about dreams and stuff like that?
Yeah, excellent. Sure, if you're trained in a theory that tells you that most conflicts have as their origin very early life experiences, then it's likely the person is going to ask a lot of questions about history, that the person who's doing the treatment may quickly move to early life experiences to see what the person can tell them about their early life. Also to kind of observe, as you were mentioning before, you observe how does a person respond when you ask them questions about their early life. Do they get agitated? Are they comfortable? Do they block on certain things? Do they tell you they don't want to talk about certain things? You get lots of clues from talking with someone about their early history. And if you're sharp in that system, you also recognize there are some things this person's not ready to talk about. Now see, in the client-centered approach to things, you just allow the person to talk about what they're ready for, and you don't push them at all. In the more psychodynamic tradition, you are probing, trying to seek certain kinds of information, but once you realize that that elicits a lot of anxiety, and we're talking now about the first or second interview, you usually then move on to other things, and you wait till the person feels safer. But you already know that this is an area of significant trouble. Also, in the psychodynamic tradition, as Mr. Jones mentioned, you might ask a person about their dreams. That's a very safe, kind of thing for someone to disclose, because the very nature of dreams, if you remember when we talked about them, is that dreams are a metaphor. The reason why dreams are so successful is because you're able to dream about express a conflict in a very disguised way so that it's acceptable to you. So if you're accustomed to listening to dreams and a person presents a very conflictual dream, if it's real early in treatment, you may not pursue it very far unless the person looks like they're comfortable enough that they may tell you some of the aspects of the dream. But Freud himself felt the dream is not very relevant. It's what your associations to the dream are that is relevant. That is, there are some dreams that are metaphorical enough that you as a clinician get real clues as to what's the nature of the problem. But to get a more profound understanding of what the metaphor being expressed is, you really want to let the client do a lot of free associating and see where they go with that. But dreams can be very safe. Okay, so now you realize that we've gone, with three very different styles. Now, one thing I should point out with the cognitive behavioral person, because of the three, we're saying the psychodynamic person asks a lot of questions, but they tend to be about early life history, and you tend just to make observations. But the cognitive behavioral person usually keeps the focus on what is it that brings you here? Like, that is, what is the presenting problem? And if you think about that from a psychodynamic perspective, you might say, or even from a client-centered perspective, you might say one of the things that happens there is you may be asking somebody to talk about the most anxious thing you could ask them to talk about, and that can be very difficult. And of course, that's true. And so part of what you have to recognize is a good cognitive behavioral therapist recognizing that the presenting problem seems to be giving this person overwhelming anxiety would cause the person to spend more time trying to be very responsive to the individual, trying to develop a trusting relationship, and the person may take longer to really get a lot of the dimensions of the presenting problem because the client isn't ready to talk about them. And one of the things that you always learn, no matter what theoretical perspective you come from, if you do not work hard at developing a relationship with the person who comes to see you, and if that person doesn't sense somewhere that they can trust you and that you care about them, they don't come back. So in many respects, no matter what your approach is, the first thing you must concentrate on is being sure that that other person who's walked in the room feels comfortable with you. Now I'm going to go on. I want to talk with you about a thing called structured interviews.
Dr. Sheridan,
Sure.
before you go on, is there a point where if a person is having dreams and I guess what I'm trying to ask is there a point where a dream becomes delusional, or can the two ever be connected, or is the dream something totally separate? I mean, if the dream keeps repeating itself.
Well, I think the way you'd want to look at it is a dream, is a story, and it's a way of a person expressing a conflict. I mean, that's kind of the thesis of dreams. One of the interesting things that happens, and it's talked about much more in psychodynamic circles, often people will, if you say to someone, if you have dreams, those are good things to bring up in our sessions. Often people will start dreaming. People even report that they haven't been accustomed to dreaming. They will start dreaming. And so it becomes a mechanism for the person to start telling the therapist about themselves, but in a very safe way. I mean, the idea of the dream, even though you as a trained person might recognize this is a dream really full of conflict, but because the dreamer is describing the dream, but the dreamer is not in the dream. It's about other people. It may even be about another era. Jung used to talk about people having dreams in which all the characters in it came out of the Middle Ages. So you've got enough distance that you can now express a dream. Now the dream may be about a war, and there may be conflict all over the place. And what you do is you simply listen to see who is the main character in the dream, and you make the assumption that's the dreamer, and you ask them to free associate about whatever that person is doing, whatever that character is feeling, whatever that character is worried about. And what you're always looking for if you take that style of approach, is for repetitive themes. So it's if the main character is always in conflict, then you realize that probably the person in front of you seems to be experiencing conflict all the time. Then you try to get the person to associate. And you're like, how is this going to work out? And you let kind of let the person go to see where did they take it. If the conflict always ends in the lead character being harmed in some way, that's a very different, you realize you're working with a very different person than if the person usually sees the main character will somehow work this out. That is, there's lots of conflict in the person, but there's optimism. Now, the difference, when you mention, in some ways, of course, one might think that a dream is a delusion in the sense that it's not reality. But delusions are usually, and dreams happen on probably everybody. Is there anybody here who never has dreamt? Okay. It's much more likely you have had dreams. It'd be more unusual if you were to say, I actually have never had a dream. But I think it would be safe, probably most of you have not had delusions. So the delusions tend to be rare. Delusions tend to be the products of very severe psychopathology that one can't find a way to relate in the real world, so one makes up an unreal world. And they do it in their psyche, and they do it so that they can kind of enhance their stature. And that's why, when delusions to some people appear wacky, they're not wacky. Usually they have real meaning, and usually they're the way in which a person gives meaning to themselves at a time when they feel they don't have any meaning. Whereas dreams often are means to express conflict. They're means to express, troubling impulses, means to communicate, perhaps even with the therapist, about what one is suffering from without having to bring it up because one is not ready to bring it up. So actually the two can be quite different. Sure.
So you're saying that when a person will see cognitive behavior therapists, they basically know their problem and they're looking for a
Yeah.
solution.
Yeah, you ask a very hard question.
Because
Big-
you said that she should ask what brings you here. So
Yes.
if I know what evidently I know basically my problem and I need a solution.
It's a tough question to answer. The difference in the theoretical positions is that the cognitive behavioral therapist is more likely to let you say what your problem is. Like, I am involved in a very bad relationship in my marriage. I think my marriage is going to break up. And the cognitive behavioral therapist would listen and say, okay, we're going to focus on your marriage and on your relationship. And the person would ask a lot of questions around what is going on in your marriage, especially what's going on recently. And would want to learn things about, what happens with your spouse. Do you have children? How are they being affected by this? But heavily on what's going on between you and your spouse, because what you have said is, I'm having this marital difficulty. Now, the client-centered person would hear the same thing, except they would probably still spend more time trying to develop a relationship with you, and they would realize that perhaps, your major problem is what's going on in the marriage, but there may be other things in your past that are causing this, and so we want to take some time to learn about that. The more psychodynamically oriented person also would attend to what you're saying, that is that you have the struggle in your marriage and it's very painful and very difficult, but they would still want to go back and see, what could you have anticipated with this person? What kind of relationships did they have early in their life? What were their parents like? In other words, their grandparents, if they were there. That is, what kind of models did this person have? Because in the psychodynamic model, what you would be thinking is, this person saw certain relationships, and then they introjected those relationships inside themselves. They developed expectations. So if mom and dad were always in conflict, if grandma and grandpa were always in conflict, and they fought a lot, and now this person, is in conflict, you might start developing hypotheses like, this person has always expected the relationship would deteriorate. It's not maybe just what's going on now, but it may have been that they've always thought this would happen, and now something perhaps minor has come up, and they've blown it all out of proportion. The cognitive behavioral therapist wouldn't be all that concerned with those kinds of things. Instead, the cognitive behavioral therapist would want to know, what are you two people doing right now that's causing this problem? How intense is it? What are its dimensions? What would you like to see as its resolution? Do you want there to be, say, less fights? Or do you want there to be more talking, more sharing of things with each other? Do you want to have more sex? Or do you want the sex if you have to be more intense? In other words, very focused on the immediate future. What do you want to have happen? And then they would begin working with you for plans like, had you ever considered doing this? Had you ever considered doing that? When you go home tonight, you've said the last 10 nights you've gone home, you and your spouse has argued. When you go home tonight, what do you think you could do that would avoid an argument? And you give the person a plan. I mean, you actually work with them on plans. You give them homework. You send them home, and they're to try this out. One of the things that will do is, first of all, obviously changes the environment right away, because the person has a plan to not argue, but rather to make things better. Now, if the person goes home and they come back and report next time, what happened? Well, we argued just as much as we always did. Did you do the things that we talked about? Well, I tried, but with that person, it just won't work. So you realize, well, the strategy you developed probably wasn't a very good strategy. It was probably the right strategy to try the first time, but it's not going to work. And so then you have to start talking, even as a cognitive behavioral therapist, about how angry do you feel with this person? Why are you so discouraged? But you're doing it in the here and now. And then after you listen enough, then you begin to plan another strategy that you can, perhaps would be safer for the person to try. But you're constantly trying to help to shift the behavior of the person so that they can try strategies that will reduce conflict. So you can see that depending on the approach you take, and let's say if you're the client, depending on whose office you walk into, you can have a very, very different experience about how you're going to handle a problem. Now, this topic that we're going to look at now, structured interviews. Structured interviews become important because we really don't have systematic data. And you can see why. I mean, this has been excellent, the questions you've just asked. You can see, depending on whose office you walk into, even though you have the same problem, it's the same you, but you may get very different questions asked of you. The person may decide to approach you in a very different way. So if you ask a global question, and in subsequent, we're going to spend a lot of time talking later about research in psychotherapy, but the problem that people were faced with is even in the first interview, just learning about the first interview, not everybody gathers the same data. So it's hard to know what is effective. Now, what does happen is that some clinical researchers have determined that only if we gather systematic data can the broader field of clinical psychology really compare the effectiveness both of psychotherapists, of the treatments they offer, and even in this case, what we're talking about, can you look at the effectiveness of their first evaluations? Also, there is a belief that there are certain factors that are important enough that every interview should probably explore those factors. That's, and by the way, that's a very arguable hypothesis, but some, especially if people are scientifically minded, they bring that up, that, you know, in a first interview there are certain things you should probably know. And what they've done is they've developed structured interviews. And structured is a word meant to be taken fairly rigidly. That is, and you'll see on page 136 of your book, they list a whole bunch of structured interviews. And what happens there is there are a sequence of questions that are asked. So if you do a structured interview, one of the things is it kind of doesn't matter who the interviewer is. Each interviewer should get about the same data. And if you want to do comparisons about interviews and about who stays in treatment or who goes to treatment and who doesn't, you've had several people, several clients, and you've had several interviewers, but they've all asked the same information. So you can see, well, what kind of information do they get, and how does the person present it, and how severe are certain problems that either lend to the person getting into treatment or cause the person to not seek treatment. Also, interview schedules, have been created around the idea that you want to form a DSM-4 diagnosis. And if you recall, when we were talking about depression, you can just look at, and if you have 4 out of these 7, then you fit into a certain category. If you have 5 out of these 10, you fit into another category. So structured interviews have been developed. So you ask about the person. I mean, you ask very specifically about A, about B, about C, or 1, 2, 3, all the way to 10, so that you can see, does the person meet the criteria for this diagnosis? And of course, if you operate in the world of structured interviews, then it's easier to do research and categorize how many people who came in to a various clinic were paranoid schizophrenic, how many had a dysthymic disorder, how many had a narcissistic personality disorder, because you've got interview styles that ask all the questions and allow you to either determine someone does have a certain disorder or they don't have it. Now, the problem with that, of course, is if you follow that, then the person presenting problem doesn't really make a lot of difference, because you already know, no matter what they come in and say is their problem, you're going to interview them in a very structured way in order to get content. And your focus and this is the danger that's often felt, is your focus is away from the client in a way, almost onto the interview itself and onto the data you're gathering, unless you do this very well. And now, you notice I'm not being terribly empathic about structured interviews because most people find them somewhat burdensome. On the other hand, ones that are thoughtfully developed can be very helpful. And they especially can be helpful if you're trying to make a decision about certain diagnoses. For example, like schizophrenia. Determining that someone is schizophrenic is very important. If you know that, then you probably also will be thinking not only about what psychological intervention should occur, but about what medications this person might be tried on. And especially if the person's actively hallucinatory or delusional, we know that medication can be tremendously helpful to this person. Or if you're trying to determine if someone is manic depressive, we already know that to not consider medication at this stage would probably be unethical, because so many people who we have determined were manic depressive actually benefit from certain drugs that you want to try them. But you don't want to just start off prescribing drugs, so the structured interview gives you a chance to determine, yes, this person really does meet the criteria of being manic depressive. Now, there are a few other things I want to mention that we have learned about interviews. They're neglected for a long time. One of them is cultural issues. And only recently have we really spent some time realizing, depending on the culture you come from, you may share information very differently. We know that in some cultures, for example, it is very difficult for women to share intimate material with men. And so when women come in and they're very identified with that culture, and they've spent most of their lives in another country where that culture treats women very differently, and now they're in a lot of stress, and somehow they're being interviewed by a man, it can be very difficult for that person to talk about her feelings. And we have made some important discoveries. For example, in one city in Chinatown, where a number of the women who were coming to the clinic actually were born and raised in China, came over much later in their lives. And they were having a lot of difficulty in disclosing certain material. And one sensitive interviewer, who himself, and it was a male who was Chinese, made the observation that when you sit down and you talk with Chinese women, you always have tea. And now most therapists wouldn't even serve you water, and certainly don't serve you tea. But in this particular clinic, they began making tea. And they had tea available in the therapy rooms. And everybody acknowledged then that as they had some of the clients come in who were natives of China, older and female, they were much more comfortable, and in some cases also gave them certain control. Like in that setting, sometimes the woman would always be the person to pour tea. So the people learned, you put the tea there and you let the person know that tea is available, and that person often would ask you, did you want tea? And you said yes, and so she poured you some tea. She had some tea for herself. Well, that's a much more comfortable environment for an interview to occur in. And the person is much more likely then to be able to talk and unburden themselves, rather than being in the sterile environment, of an office where, here's the interviewer, here's the client, and this is someone who is from the countryside in China. I mean, that's such an incredibly different world. Now, you also have the issue of closing the interview. And a great deal happens if we're talking about a good interview. First of all, the interviewer becomes aware about what the suffering person presents as a problem. So by the end of the interview, you certainly know what is the reason for why this person thinks he or she came. Then, a good interviewer develops some hypotheses about what really is the problem. That is, the fact that the person presents doesn't necessarily mean, in fact, we've often said this, doesn't necessarily mean what they present is the problem. So you may have to hypothesize what are some of the more complicated issues that are going on in this person's life. And if you've done a good interview, you certainly should have some idea about what are the strategies that might be used to intervene effectively in this person's life. So those things you want to accomplish. Now, as I've been saying repetitively, actually, when all of that is going on, your still primary aim is to develop rapport with the person with whom you're working. And that's true no matter which of the theoretical perspectives you come from. Now, there really is, unfortunately, significant research that shows in settings like mental health centers, more than half the people who come for a first interview don't come back. And I mentioned just earlier, I think some of the reasons for why that happens is that there's so much focus on assessment, there's so much focus on gathering data, and less focus on getting the client hooked into treatment. And that's why in crisis centers that are good, crisis centers allow the person to come back and see the same person a number of times. Even if you know that they're going to need longer-term treatment and you eventually are going to refer them to someone else, you tell them in the beginning you're going to see them for 3 or 4 times or whatever, so that they'll come back and you make the appointment. And then when you think they're more ready, you refer them to someone else. Now, at the end of a session, it's very helpful to convey to the client that you actually do understand his or her problem. It's not enough to just understand it, but you need to let the person know that, that you do understand their problem. You may have to even tell them what their problem is, which at the end of a first session may be whatever they've told you it is. You also want to convey to them, so that you're clear yourself, what you think the client is asking for. So in case you've missed something, the client can correct you and say, well, no, that's not really why I came here. And also you want to tell the person whether you feel treatment would be helpful or not. And obviously in the vast majority of cases, you're going to tell them that further treatment is necessary and that you think it would be helpful. Now, if that's the case, then, if you're going to say there's going to be treatment, you want to describe to a person what treatment will be like. It is amazing sometimes how we make these assumptions that, everybody has been to college and majored in psychology. And so they know what to expect. I mean, the vast majority of people who walk into any kind of mental health setting have no idea what to expect. Or worse, their idea is that their closest association is they saw the movie One Flew Over the Cuckoo's Nest or something like that. That's their view of things. So you got to tell them what is going to be expected. So you might tell them how many sessions might be necessary for them to be in treatment. You have to tell them how much the sessions will cost. It's not an unimportant issue. You want to tell them the length of each session. You want to tell them the frequency of sessions. Very different, being seen once a week versus 3 times a week. You also want to let them know, if these are people who have insurance, whether or not their insurance policy covers the cost of this treatment. And if it does, you may also have to tell them that it only covers a certain amount of it, or that there's a limited number of sessions that their insurance will pay for. But you want to let people know this. Very importantly, you want to let them know the confidentiality that they can expect from the therapist. That is, you want to let them know that this is a protected relationship, that the law is such that you can't disclose, nor can anyone else who's treating them disclose information about them unless they give their permission. You also want to let them know how to cancel an appointment. It's amazing, sometimes people, therapists themselves, especially if they're in their beginning stages, get upset that someone didn't come. But if you ask them, well, did you describe to the person exactly what they should do to cancel? They say no. And the client actually thinks, well, if I don't show, I don't show. And the client may not show for any number of reasons. One might be that they don't feel they can afford it. Another might be that something came up in their family and they just made a decision that was more important. Frequently, the reason is that the therapies become frightening. They want to avoid it. But you have to tell them how to cancel. And also, in some cases, you have to tell them what risks there might be in the treatment. In some cases, somebody comes in and tells you a terrible story about their marriage, and if you listen, and they have a very abusive spouse, the spouse is totally unmotivated to change. You see bruises on the person who's in front of you. You may have to let them know that one of the outcomes of this may be that you have to come to grips with the fact that you can't continue this relationship. And whether you actually tell the person that or not depends on just how ready you think they are to hear it. But that could be construed by some people as a very negative outcome. Now, there are some other things that you need to be aware of. For instance, laws have been passed in some jurisdictions recently that require a psychotherapist to release certain information. If a client comes in and says they have abused their child, there are some jurisdictions, at that point, you have to inform the client that you have to inform the authorities that they are abusing their children. You don't even have the choice of seeing whether or not you might be able to treat the person and you might be able to stop this, that it's just been decided legally that anybody who's a child abuser should be reported. Now, there are other cases where it's a judgment call for the interviewer. You interview a person and the person says, I feel like killing my boss. And that's really why I'm here. I'm having these murderous feelings and fantasies. I even dream about killing my boss. Well, there are jurisdictions where the law says, if you think this person might harm another person, you actually must inform the other person. Now, the difficult part of this, but it's right in most laws, you only have to inform the other person if you, the clinician, actually believe the other person is likely to harm, that is, your client is likely to harm the other person. If your judgment is that, no, I don't think they'll do it. I think this person is very angry. I think this person does feel that kind of rage, but I also think we can deal with that in our sessions. I think that's why the person has come here, is to avoid acting on these impulses. So I don't think that this person will do that. Then you are not required to disclose to another person that somebody is having murderous thoughts and feelings and impulses about them. Now you might wonder, what is the liability of the clinician? Supposing you're wrong. Supposing our person actually does get more murderous and goes out and harms or even kills the person that they had told you they were feeling this way about. What is your liability? What the courts are saying is that, it's very unfortunate that you missed this, but we already know that clinicians are very poor predictors of this, and we don't want every person who has murderous impulses to not be able to disclose those in the confidentiality of a psychotherapeutic situation. So we don't hold you responsible. As long as, your view was the person would not act on this, then you're not obligated to inform. Also, in today's world of technology, and it's all, especially in terms of movies, it's important that interviewers tell clients that you do not tape record your sessions. And that if it ever came to a point where you wanted to tape record, you would need the client's permission before you could do it. there are many people who just assume, somehow before they came into the office, the therapist pushed a button and they're recording the session. If any therapist did that, by the way, that would be a totally unethical behavior. You may never tape record a session with someone unless you have gotten their permission to do so. Now, they're also in your book, they mention a couple of other well, I don't know why they put this in interviews, except maybe they couldn't figure out another chapter, but they talk about naturalist observations. And psychologists haven't really participated very much in naturalistic observations. Anthropologists have. I mean, anthropologists have gone, and lived with families, lived in different cultures, and observed, what happens. And in fact, nursing staffs are more likely to participate. In fact, they much more make naturalistic observations on inpatient units, and they write up their observations so that in the person's record, you can see what the nurses have observed about a person and how they're doing. But psychologists haven't done much of this. And I would recommend to you, there's a movie that came out last year called Kitchen Stories. This is a Norwegian movie. It won the top prize in Norway, so it has subtitles. But Kitchen Stories is this very interesting story about social scientists who are assigned by a company that sells kitchen products to observe single men, or at least men who are living alone, in the Norwegian countryside in their kitchen. So they send out this group of interviewers, and they're going to spend, I forget, a couple of months, I guess it is, in which they come in every day to this person's kitchen. And they bring with them a high chair, like the kind of chairs you see that tennis referees have, where they sit up above everybody and look out. Well, the guy comes in and he puts this chair up in the person's kitchen. And then they sit there with their pad, and they spend 8 hours recording everything that goes on. As the person walks into the kitchen, they record. The person comes into the kitchen. The person's going to cook a meal. They record what they're going to cook. They record what kind of pots and pans they're using. They record whether they sit down and eat, et cetera, et cetera. Now, the fascinating thing with this is the interviewer, who's in this person's house with only one other person, every day is to have no relationship with the person. And the movie unfolds about the impossibility of having someone be an observer and have nothing change as a result of having this isolated person on a farm now having somebody else in his house every day. And it's done extremely well. And it really gives you this tremendous sense about how over time things will change with any kind of naturalistic observation. That is, you really can't say we're going to observe someone, and we're going to do it though as if we're not there. There just is no evidence to suggest that. Well, the evidence is the opposite. It suggests if somebody is there observing, that will change the nature of what goes on. So the data that you gather as an observer, naturalistic observer, is probably not accurate data about what would happen if you really weren't there. So your authors throw that into that chapter, but it's really not something that psychologists participate in.
Well,